I say that RDS is somewhat of a vicious cycle. And I say that because what we do to help the baby also hurts the baby. So whenever we put a baby who's premature, doesn't have enough surfactant, on a ventilator, we can create shear stress by opening up those alveoli and allowing them to collapse again. So we have to really watch the PEEP levels. And at the same time, the baby's probably not going to have enough oxygen going through the body simply because there's not enough FRC. And what we create is not natural. So the FRC is not going to be optimal as it would be if the baby was born on time, on its due date. At the same time, because there's not enough oxygen going through the body, there's some vasoconstriction happening. The vessels are going to be constricting to try and increase the PO2. So we've got alveoli not open all the way at the same time as vessels being constricted. So what do? We give them more PEEP or CPAP. And that can cause, again, overdistension. So we're trying to help the baby, but at the same time, we're causing issues with the baby. That's why I say it's a vicious cycle. So as we're helping them, we're also going to be creating some inflammation if we cause overdistension, barotrauma, shear stress, those types of things. We try to help the oxygenation. As we try and help the oxygenation, we could be injuring the alveoli. Injuring the alveoli makes those cytokines come as part of the white blood cells. That creates lower oxygenation. That makes the vessels constrict even more. So we try and give more PEEP and more oxygen. Now we have O2 toxicity, and now we have shear stress and overdistension, and cytokines, more vessel constriction. So what do? Give more CPAP and more oxygen, which again creates more cytokine, shear stress, barotrauma, vasoconstriction, those types of things. That's why I say it's kind of a vicious cycle, and we just have to try and keep ahead of it. As a respiratory therapist, our job is to make sure air is going in and out and blood's going round and round. Those two things are happening, we're going to have a pretty good day. However, when these kiddos are born prematurely, there's not enough surfactant and their alveoli are going to be collapsed, which means they're not going to be oxygenating optimally. Therefore, their pulmonary vessels could be constricting. So now oxygen's not diffusing across because of the RDS, and it's not going to come into contact with the capillaries because the vessels are constricting because there's not enough oxygen. A couple things that we can give to help with that vasoconstriction. One is nitric, which we've talked about before, and another one is Flolan. They both do the same thing. Nitric is something that we give with an additional machine. Some people say the machine's a ventilator. It's not. All it does is give nitric. And we want to start usually at 20 parts per million. We can start at 40 parts per million. I've seen it people start at 60 parts per million, and I've seen as much as 80 parts per million given. 80 is quite a bit. 40 is pretty average for starting out, and then we decrease it to 20, then 10, then 5, then 2. So you will decrease it by half. Flolan you may have seen in the adult critical care units. It's given with an ultrasonic nebulizer type of device called an airgen nebulizer. And sometimes you can see it given through IV even. Those two drugs, nitric and Flolan, are very good to treat pulmonary vasoconstriction. So you may see those given. Babies born prematurely have something called a honeymoon phase. The honeymoon phase is when things are great and wonderful and everything looks perfect, and then boom, it's not. We've talked about this before, I believe. And you can refer it to, people say, the honeymoon phase of a relationship, when you've got all that puppy love and stuff going on, and then when real stuff hits, it's like, this is not good anymore. So that's kind of where they get the term honeymoon phase. These babies are born, they've got all the mom's nutrients, the blood, and all that stuff from mom still floating around in their body. But then as that is metabolized, they're on their own. That's when the honeymoon phase is over, and that usually takes 2 to 3 days. So I've seen babies born really premature. I'm talking 25 weeks. They had surfactant. There's no way it's mature. And they look great. And we're just like, is this the miracle baby? No. Don't ever think that. Always be prepared. Always be thinking, what if, what if, what if? So whenever you have a premature baby being great, breathing great, no retractions, no grunting, 25-weeker looks fantastic, to start thinking, what if this is when they start having retractions? What if this is, going to happen next? And so, like I said, the honeymoon phase usually lasts a day to 3 at the most. And they'll look great, and then all of a sudden they'll start grunting, and then you'll start seeing some retractions, and you're like, well, honeymoon phase is over. Time to break out the high flow nasal cannula, time to break out the CPAP, time to start thinking about what to do next. This is the chest x-ray of a neonate who has RDS. A couple things I want you to notice. First of all, look at the ET tube. It looks like it's going into, I don't know, the right atrium or something. That's often how it looks. It looks like it's displaced. It looks like it's going into some foreign place the ET tube should not be, and it's going to appear rather high. The ET tubes for neonates in the preemie will be at about the level of the clavicles. You know, babies aren't very big, so that means the ET tube is going to sit about right up here. This is where my clavicles lie, right here. So the ET tube, if I were a neonate, would be about right here. So it's not going to go down to the carina. It's not going to be two centimeters above the carina. It's going to be, look for the clavicles. It's going to be about at that level. And babies rotate very easily, so that's why it looks like you've got an ET tube that's really going into the central vein or something like that. That's common. Breath sounds, chest x-rays, chest movement, be looking at all those things. So that's the first thing I want you to notice. ET tube at the level of the clavicles, and it can look like it's way out of place, but that's kind of normal. Okay, so the second thing is this is RDS, and you know from your chest x-ray chapter a long time ago that RDS will have something called ground glass. I have yet to see ground glass that looks like an x-ray. So a lot of people say it looks somewhat like a snowstorm if it starts snowing really heavily. Do you look outside the window and you see, you know, it's at night and you see all the snow coming down? That's what this ground glass or ARDS looks like. When you look at this x-ray, I hope that you see the air bronchograms. And I know that last semester when we talked about chest x-rays, air bronchograms were associated with pneumonia. That was the adult world. This is the baby world. And if you remember correctly, the air bronchograms simply mean this. There are airways full of air sitting in front of tissue full of junk or atelectasis. So if your airways are full of air and the alveoli are collapsed or full of mucus or something like that, you are going to get an air bronchogram. In BRC world, think of pneumonia, but in the real world, especially in the NICU, think of RDS. This is what RDS at chest x-ray looks like, kind of like a phase 2. So after those first few days are over, the x-ray will start looking like this with air bronchograms. This chest x-ray is bad. That's all I can say about that. It is bad. By the time you get to this point, there's so much inflammation and scarring that this baby will never have normal lungs. This is where the babies are like baby COPDers because of all the inflammation, shear stress, that type of thing. Whenever you see this, remember black is good, white is bad, and you can see all the white kind of scattered through. That's inflammation. That is scar tissue. This baby's going to have alveoli that are stretched out like a COPDer, but yet other areas that are fibrotic, like pulmonary fibrosis. So this is not a good scenario. Babies do make it through this. They do live through this, have a pretty rough life, as in, you know, their activities of daily living are not going to be like other healthy kids that were born when they were supposed to be. They are going to be on oxygen for a while. They are going to have trouble with feedings because if you have a hard time breathing, just sitting there, imagine now trying to eat and breathe at the same time. So working on feeding these babies is not easy, and you'll see that this baby actually has a feeding tube in. You can see where it goes into the stomach. So this is kind of like RDS phase 4. We're going to talk about that in a little bit, but this is where we talk about bronchopulmonary dysplasia, BPD.